let's start the show. So today we are trying to talk about the oxygen therapy and respiratory failure and how to use our non-invasive ventilation in our unit. So oxygen therapy. So oxygen therapy is that the oxygen we inspire from the air is actually roughly saying 18%. But to make the life easier for easier calculation, I think let's say 20%. 20%. The air we breathe now is 20% oxygen. All right. So any additional liter of oxygen we add, we need to plus 4%. So that means someone is needing the 1 liter of oxygen, meaning that another additional 4%. So a person needing the liter of oxygen is going to be room air. At the same time, he is breathing the room air besides this nasal cannula. So the total oxygen he is getting is 24%. And the reason I make it 20 is easier for calculation rather than saying the real digit of 18%. So for example, someone needing 5 liter of oxygen, so every liter is 4% multiplied by 5 liter. So that particular person is needing an additional 20% on the top of the room air we breathe. So 20 plus 20, he is getting the 40% oxygen. All right. So up to 5 liter of oxygen, we can give with the nasal cannula. But beyond 5 liter, we should use the nasal brown mask. The mask, nasal brown mask. So for example, someone is needing 8 liter of oxygen. 4 multiplied by 8, 32, plus 20% from room air, so 52%. So someone needing the 15 liter, I mean, this nasal brown can be given up to the 10 liter oxygen. So 4 multiplied by 10 is 40 plus 20% from room air, 60%. Okay? So someone needing 10 liter oxygen is a little warning sign. 60% pure oxygen is quite a big dose. Compared to what we breathe, 20%. The person is needing the 3 times higher oxygen requirement than what we usually breathe. So 5 liter to 10 liter, we use the nasal brown. 1 to 5 liter, we can use the nasal cannula. Beyond 10, we need to use the non-rebreathing mask. Because there is a reservoir there. So whatever amount can stay there and without wasting anything. So for example, someone needing the 15 liter oxygen is at 1 liter, every 1 liter is 4% multiplied by 15, make it 60%, plus at the same time 20% from the room air, 80% oxygen. So this is how it works. And after that more than 80%, we need to use our HFNO machine, high flow nasal oxygen machine. What we use is called Airvo. This is the company name. But the official name, scientific name is high flow nasal oxygen machine, HFNO machine. HFNO machine can deliver more than 80%, until almost 100%, but usually we use a 90, 100. So the HFNO machine is the this one doesn't have the water circuit to moisten the air. So, but HFNO machine has the machine contain the water circuit to moist the air. So that prevent dryness of the airway mucosa. And this is the rough idea of how the oxygen therapy works. Today is 19th of May 2022. So, do you have any questions regarding this page? No. All right. So, we shall go to the next. Can you see me from there?
Yeah.
Is it all right?
You can see the board but then half your face, but
No, yeah, like that is fine.
All right. Head is cut off.
No, you're all in.
Okay. Another thing we need to talk about now is, yes, we need to know about the type 1 respiratory failure and type 2 respiratory failure. Type 1 respiratory failure is, yes, we all know oxygen drop, but carbon dioxide, normal. Alright, but type 2 respiratory failure is, usually yes, they also have the oxygen drop, but sometimes it can be normal, but definitely carbon dioxide increase. So this is the main definition between the type 1 respiratory failure and type 2 respiratory failure. Alright. So how would we define the oxygen drop, hypoxia? Hypoxia is peripheral SpO2 is less than, I would say 94% actually in reality. Or in ABG, PaO2 less than 8. So this SpO2 and PaO2 have the very linear relation. All the scientific study found that there is a very linear relation between peripheral SpO2 and PaO2. So in reality, as far as you can measure SpO2 properly with good perfusion, you don't need to have this ABG. As far as your patient maintaining the SpO2 at 94%, we are very sure that PaO2 is above 8. Alright. Not always ABG is required in type 1 respiratory failure, as far as you can manage to measure the SpO2 properly. Sometimes they may have the cold and clammy, they may have the fingernails vanished. So something is disturbing for the SpO2 to do properly. Yes, we do need the ABG. Sometimes cold peripheral shutdown, perfusion is not good. Sometimes we use the earlobe, very cold, kind of clammy, in shock. Sometimes SpO2 cannot be useful. In that case, ABG might be absolutely required. But as far as you can manage to get SpO2 measurement, we are sure that PaO2 is very linear coefficient equivalent to SpO2. But that is not, we know that is not true for the carbon dioxide. Alright, we don't know, we will never know by looking at the SpO2 for carbon dioxide. Alright, but in type 1 respiratory failure, we know that if you are very confident that your patient is type 1 from the beginning, and we are not worried about CO2, we don't need ABG all the time. But this is not true for type 2 respiratory failure. SpO2 won't tell you what happened to carbon dioxide. So in type 2 respiratory failure, ABG is must. ABG is must. Without ABG, we don't know how to deal with this type 2 respiratory failure. So after talking about the oxygen hypoxia definition, hypercapnia definition is PaCO2 more than 6.5. All right. So this is called hypercapnia. So some decimal figure, I might be wrong, but around there. And so this carbon dioxide. So now we go to the type 2 respiratory failure, okay? So before going to the type 2 respiratory failure, we need to know how our body handles carbon dioxide, okay? And one, yes, this is a lung, this is a kidney, this is a ureter. So carbon dioxide retained in the body go out from the lung. We all know that. Okay? Someone who cannot afford to exhale the carbon dioxide from the body, carbon dioxide retained in the body. After that, that carbon dioxide retained in the body bind with water in our body. Alright? After that, it becomes the H2C3O. H2CO3. It becomes the carbonic acid. Alright. After that H2CO3 go to the kidney, and after that it breaks down as 1H plus, 2H, another H go with HCO3 minus. So this is how the carbon dioxide mixed with water, and how carbon dioxide turn into H plus acid and HCO3 minus alkali bicarbonate. And so these acid and kidney obviously cannot handle carbon dioxide. Kidney cannot breathe. So that carbon dioxide need to transform to something adaptable with the kidney. So yes, of course, kidney can excrete the H plus and HCO3 minus S in the urine. All right, so that's how the carbon dioxide handled with the help of the kidney in the body. This is called this is equation. This all done by the carbonic anhydrase enzyme. You don't need to know actually. This is a biochemistry. You are not sitting for the MCQ exam, but just for rough idea. This equation was done by the carbonic anhydrase enzyme, and this is called the Henderson-Hasselbalch equation. This equation was created by the scientist called Henderson-Hasselbalch. So this equation is the Henderson-Hasselbalch equation, and this process was run by the carbonic anhydrase enzyme. So one of our carbon dioxide race, definitely H2CO3 race. Alright? After that, it ended up with the H plus 2 race. It became acidosis. So that's why in type 2 respiratory failure, why patients keep on rising the carbon dioxide, and later they develop acidosis, pH drop. Okay? pH drop. So our definition of acidosis is less than 7.35. And carbon dioxide must be elevated, more than 6.5. This is our definition of acidosis caused by carbon dioxide. So this is respiratory acidosis. Okay? After that, one carbon dioxide raise, H plus raise. So what kidney is doing? Kidney is trying to remove the increased H plus in the urine. But any molecule of H plus going into the urine, kidney is taking another molecule of bicarbonate exchange. So every single unit of molecule of H plus going out in the urine, body saves another molecule of bicarbonate to balance the ion equilibrium. That's why people with respiratory acidosis have a high bicarbonate. High. They used to have above 30, mostly. Actually, normal value is 28. I couldn't remember exactly, but around there. So, how to interpret this is acidosis. After seeing the acidosis, look at the pH first. This is acidosis. After acidosis, we need to decide whether respiratory acidosis or metabolic acidosis. So look at the carbon dioxide second. If carbon dioxide raised, this is respiratory acidosis. And look at the bicarbonate third step. Bicarbonate is not low. If bicarbonate low, yes, this is metabolic acidosis. But bicarbonate high means this respiratory acidosis has been trying to compensate it by saving the bicarbonate. So this is a compensated. So respiratory acidosis compensated. All right. Any questions? This is how we handle the carbon dioxide in the body. And this is how rising the carbon dioxide causing the acidosis. Your patient came in with pH of 7.45. Carbon dioxide of 7. Not acidotic yet. Carbon dioxide is high. 2 hours later, pH dropped 7.3. Carbon dioxide became 9. Because this happened. All right. So this is how it happened. And after that, bicarbonate is 40. Because trying to compensate. Kidney is trying to excrete the H plus and bring in the bicarbonate. So the bicarbonate is getting higher. You need to be careful with this patient. If you see someone is bicarbonate approaching 40, they are going to crash soon. Because kidney is going to lose its ability to compensate. And after that, kidney cannot handle the acidosis, and after that, your patient is going to crash. So, yes, we do look at the pH, very important. We do look at the carbon dioxide, very important. At the same time, don't forget to look at the bicarbonate. If your patient bicarbonate coming with bicarbonate of 30, after 2 to 3 hours later, bicarbonate becoming 40, and respiratory rate is increasing 40. Patient looks more distressed, more drowsy. Be careful, they are going to crash. Any questions? Okay. So now we talk about type 1 respiratory failure, type 2 respiratory failure. We all know that type 1 respiratory failure, 3 main indications for giving the non-invasive ventilation. One is pneumonia. Whatever pneumonia, COVID or non-COVID, or community-acquired pneumonia or whatever, hypoxic, not hypercapnic, yes. This is an indication for the oxygen therapy and the non-invasive ventilation as required. Pulmonary edema. So left ventricular failure. This is the second indication we use, especially the CPAP. CPAP has an additional advantage of pushing the air, water into the blood vessels from the alveolus. So that's why we use the CPAP in pulmonary edema. Third indication is ARDS, whatever ARDS, COVID or non-COVID or acute respiratory distress syndrome. All right. So we are HDU setting. We are talking about non-invasive ventilation. I'm not talking about the invasive and ventilation. Invasive ventilation we do in the ICU, intubation and ventilation. That's why I intentionally not include asthma here. Alright, actually asthma is still type 1 respiratory failure because mostly the asthma patients are very tachypneic and they wash out the carbon dioxide with. So usually they are hypoxic, but their carbon dioxide also low because they are very tachypneic and washing out the carbon dioxide. But asthma patient, oxygen low and carbon dioxide normal, you need to be extra careful. This is a danger sign in ABG. Normal carbon dioxide in asthma patient is you need to call the ICU. You need to inform them. Your patient is start tiring. Don't be happy with normal carbon dioxide in severe acute asthma. It is one of the life-threatening signs. One of the life-threatening signs. You need to inform ICU. They might need intubation. They should be cared in the place where the immediate intubation is possible within 3 minutes. We can keep here. That's why we never bring hypoxic asthma, never, ever bring to the HDU. Because we can intubate within 3 minutes. Brain will die within 3 minutes for hypoxia. So they should be cared at the setting where the immediate intubation can be possible. So life-threatening asthma patient, ideal setting to be cared is in the ICU setting. They might still use the non-invasive ventilation there, but they can intubate immediately. We can't. Alright. So that's why if you bring asthma to HDU, what manager is going to ring you? Why are you bringing the heat? Have you already contacted to the ICU? Have they seen the patient? She will ask you a lot of questions to you. Please prepare to answer. So that's why I didn't include the asthma intentionally in this type 1 respiratory failure. That the asthma is not for the HDU setting. Yes, carbon dioxide increasing in asthma is not good. Not good. They definitely need to be intubated. Alright. If asthma go into type 2 respiratory failure, it is near fatal asthma. Alright. So in our HDU setting, the 3 indications for using the non-invasive ventilation are pneumonia, pulmonary edema, ARDS, whatever COVID or non-COVID. So type 2 respiratory failure, we all know main indication is COPD. OSA, obstructive sleep apnea, obesity, hypoventilation syndrome, OHS, and other causes of respiratory failure. Could be central or could be local. Central means the brain, the brainstem stroke, the brainstem bleed, or whatever, or whatever, multiple sclerosis or whatever, all the central causes causing the respiratory center to be depressed. So as a result, respiratory muscle paralysis. Local means that maybe the intercostal muscle or diaphragmatic muscles or whatever muscles, and causing sometimes a cervical cord injury and causing a diaphragmatic paralysis. So all the respiratory muscle mechanism failure, mechanism of respiration failure. So these are the three main. The Guillain-Barrés they are also included in the local because Guillain-Barré is a neuropathic, causing a neuromyopathy causing a myopathy, muscle weakness of the respiratory muscles, and Guillain-Barré, myasthenia gravis. These are the type 2 respiratory failure. All right, and this is important. How do we know who are likely to be type 1 or who are likely to be type 2 without having the ABG? Because we know that SpO2 is useless in type 2, still useful for oxygen, but cannot be used for the carbon dioxide. So how can we expect who is likely to be type 2? Look at the body figure. Yeah, obesity, hypoventilation. They used to be obese, and COPD, we know that COPD may have a COPD feature. Usually they are very thin and emaciated, and signs of positive breathing. They're trying to control airway breathing because not to prevent airway to collapse and hyperinflated chest, so on and so forth. So someone you think likely to be type 2, yes, ABG is required. So to know that what's going on with the carbon dioxide, especially if they are not saturating 88 to 92%. If they saturate less than 88%, or they are drowsy, yes. So ABG is a must. All right. Any questions to this? No. All right. Okay. Don't fall down. Sleepy. Okay. So where are we going now? Where are we going now is we talk about the oxygen therapy. We talk about the respiratory failure, 2 types. We talk about how our body handles the carbon dioxide excess and how acidosis happen and what are the causes, indication for type 1 respiratory failure and type 2 respiratory failure. Now we go to the control oxygenation. Control oxygen therapy. What does it mean, control oxygen therapy? What does it mean, control oxygen therapy? For example, your patient, SpO2, okay, is 85% on room A. Okay? On room A. When you examine the patient, you suspect the patient might have COPD. Alright. Chronic smoker, blah blah blah, plethoric phase because of polycythemia, because of chronic hypoxia. So in that case, oh yes, we aim for the target. Okay, this patient at least we will maintain for 88 to 92%. We set the target. After that, we give the oxygen. Okay, 1 liter, 2 liter, 3 liter, 4 liter, 5 liter. Until 5, you are not achieving 88, only 87%. Still hypoxic. All right. We calculate. What does it mean, the 5 liter? 4 multiplied by 5, right? Additional liter is 4%. Additional 5 liter is 20%. Plus room air is 20%. So your patient is getting the 40% oxygen already. All right. So are we going to jump to 8 liter or not? No, because the COPD patient are actually sensitive to oxygen. How can I say? In the brain center, in the brain, medulla oblongata, spinal cord, in the respiratory center, there is a chemoreceptor. They are the oxygen sender. They are the oxygen sender. Actually, respiratory center run by the oxygen sensor, not by carbon dioxide sensor. Respiratory main stimulus for the respiratory center and the brainstem is oxygen, not the carbon dioxide. The trigger is. So that means that whenever you have the hypoxia, yes, it is activated, and it will drive you to breathe more. All right. So to be activated, brain center need the hypoxia a little bit. So these COPD patients are they are run by a hypoxic respiratory drive. These COPD patients are respiratory stimulus is driven by the hypoxic respiratory drive. So they really do need to have the hypoxia a bit to drive their respiratory center to be awake. So if you give too much oxygen, you wash out all the hypoxia, their respiratory center won't be activated. So that's why too much oxygen is harm for the COPD patient, type 2 respiratory failure patient. Because brain center will be activated by slight hypoxic drive. And when you give too much oxygen, you are washing away hypoxia all, and you are causing without any activation onto respiratory center. After that, their respiratory center fail after the carbon dioxide retaining as a result. So that's why if you give too much oxygen, why carbon dioxide rising? All right, this is called a hypoxic respiratory drive, mainly in the type 2 respiratory failure patient. So in that case, if you give 8 liter, 4 liter for every liter, multiply by 8 liter, 32, plus room air is 20, 52. If you give 8 liter without control, it will abolish hypoxia at all, and chemoreceptor and oxygen sensitive chemoreceptor won't be activated. After that, respiratory center will fail. So that's why traditionally we used to say that type 2 respiratory failure patient should be 24 to 40% maximum oxygen. We shouldn't be given more than 40% in someone with carbon dioxide retention. All right. So obviously, yes. Obviously, your patient, you are reaching the maximum 5 liters. So that's why rule of thumb, don't give more than 5 liters for someone with type 2 respiratory failure risk through the nasal cannula. You are trying to causing the carbon dioxide retention by more oxygenation. But the problem is your SpO2 is not achieving. Hypoxia is a problem. We still need to give more oxygen. But we are not allowed to give. So there is a place where the NIV pipette step in. Pipette will help control oxygen at the same time washing out the carbon dioxide. So pipette will help to bring out the hypoxia at the same time blowing out the carbon dioxide. So there is a place where our bi-level intermittent positive airway pressure, pipette, bi-level, bi-valve. So there's a place where the pipette step in. You cannot go more than 40%, but your patient is still hypoxic. We need to bring the oxygen up without any risk of carbon dioxide retention. This is a place for the pipette. Okay? All right. Here also, we use the Benjuries mask, control oxygen. Sometimes we use the Benjuries. Benjury has a color code, right? I think we shouldn't go beyond green, I think. Green is a maximum. I couldn't remember detail, but definitely red is not for type 2. They make it red. It's a 60% or something. Benjury color code red is for type 1 respiratory failure. Red you cannot use. Red is a danger sign. Intentionally they make it red for you not to use in the type 2. I think we can go beyond green, I think. There are blue, white, and yellow or something. Color coding system there. I couldn't remember today. Percentage. Maybe nothing staff might know better than myself. So the control oxygen can be delivered with a Benjury. Yes. But we shouldn't use Benjury masks beyond the green. So this is called the control oxygen. After that, we will go into the non-invasive ventilator. Any question until now? Okay. You need a break? No.
Good.
Alright. Okay. Sorry, I'm talking so much. So I need something to drink. Okay. Not an hour yet, right?
45 minutes.
Okay. So now we will go to the non-invasive ventilation. Okay. Non-invasive ventilation. I will leave the HFNO later. All right. Yeah. Okay. Better tell at the same time. Type 1, type 2. Type 1 should be very quick. Type 1 usually, if you cannot maintain more than 15 liter non-rebreathing mass, yes, we go into HFNO or either CPAP. Alright. High flow nasal oxygen, CPAP. Yes, high flow nasal oxygen, advantage is good, max is not tight. Not as tight as CPAP. CPAP is we know that they're very tight mask, like the fighter jet pilot mask. Alright. It's more discomfort than that, I think. So advantage is this is the good, comfortable, and comfortable. Alright. And that is and the CPAP has the pressure setting. We can adjust the pressure. But centimeter water. Centimeter water we cannot adjust. Yes, here centimeter water we can adjust. Alright. We will come back to type 2 later on other page. It's going to be a little busy page. So in terms of oxygen, yes. When we talk about the oxygen, there are two measures we need to tell. Alright. Quality, volume. Alright. Whenever we talk about the oxygen, there are two things you need to write. How purified oxygen you want to give. For example, if you want to give the 80% oxygen, alright, you want to give the 60 liter per minute. Alright. So purification, we know that how purified the water is. pH 7, pH. So the oxygen is so purified, 80% is clear oxygen. So this is the quality of the oxygen. Volume is how many liter per minute you want to flow. So in other terms, even though HFNO machine doesn't have the pressure setting, they don't have, actually the volume is actually pressure. Like a bucket of water. You fill more water and you throw, the force will be more whenever you fill up much. So volume is in the other term is also partly of the pressure. Even though the HFNO machine doesn't have the pressure setting, as far as you increase the liter per minute, you are giving some pressure to make the airway to make it open. Okay? So that's why it's not always true HFNO machine we cannot use in pulmonary edema. No, yes, we can still use. Because it still has the pressure head. More than your non-rebreathing mask. Okay? Non-rebreathing mask, the patient need to breathe. And the air is not going in with force. But this one is, no matter how patient breathe or not, air is going with the pressure. So CPAP machine. But CPAP machine has we can adjust the pressure setting, centimeter water. Alright. Sometimes we call it P. Actually, it's not the correct term, but we use it. Peak and expiratory pressure. Peak and expiratory pressure. P. So usually we start with low. Start low, go slow. Start low. Start with a 6, 8, 10. Never beyond 10. For the pneumonia, ARDS, pulmonary edema, COVID, ARDS. We rarely go beyond 10. Okay? I will tell you why. P. What does it mean in P? P and expiratory pressure. So this is a small airway. This is the alveolus. Okay. This is the lung. This is the diaphragm. Okay. When we breathe out, intrathoracic pressure increase. Diaphragm go up, chest wall squeeze, and pressure inside rising up. And pressure to the alveolus from outside also rising up. That's how the air was. We breathe out. Okay. So end expiratory, at the end of the expiratory, what happened is this alveolus collapse. All right, collapse. But those patients with pneumonia, ARDS, pulmonary edema, their lung is not as good as ours. Their lung is lung injury, acute lung injury. When we have the injury, when we have the pain, we don't want to move. We try to avoid moving. We don't want to move like this, right? When we have the injury. The same thing, alveolus, they have the acute lung injury. Actually, we try to avoid too much moving of the alveolus. That's why we don't want them total collapse. If they have the total collapse, they have all the secretion, they stay together and very difficult to reopen. All right? And even we can reopen, it will split up. It will tear up. So it is called a barotrauma. So the aim of the treatment is to prevent the total collapse, at the same time to make ready for opening slowly. That's why CPAP, breathe out. Near at the end, CPAP is blowing a little bit pressure to prevent the total collapse of the alveolus and small airway. That's why the name comes from it. End expiration. At the end of the expiration, CPAP is delivering small peak pressure to prevent the total collapse and the atelectasis of the lung and to prevent the lung injury. So they are ready for reopen again. They are not stick each other. So that's why CPAP pressure cannot be too much. If you deliver too much, you are also tearing out at the injured alveolus. And at the same time, you can imagine that patient is breathing out, not natural way. CPAP is blowing, pushing the air into against the expiration. So if you increase too much pressure, they feel suffocate. They can breathe out. If you increase too much CPAP pressure, they will complain to you. Doctor, dear staff, I can breathe out. Because blowing in is not a problem. Then go along with the stream of the flow. All right. They won't complain about the inspiration. Because while they inspire, CPAP is blowing in, it doesn't matter. The air is flowing alongside with the breathing effort. But at the time of expiration, if you increase CPAP pressure too much, it is pushing the air not to come out while breathing out. So patient feel of suffocation. So usually, yes, we use the CPAP in pneumonia, pulmonary edema, ARDS, as we discussed before. Yes, we start low, we go slow, and not more than 10, most of the case. Someone needing more than 10, call ICU, they need intubation. All right, or you decide to palliate if they are not for intubation. Okay? Or we go sometime more than 10 for those who are not suitable for intubation and no other choice, otherwise they are going to die. To save the time, to buy the bridge for the time, sometimes we go beyond 10 for the do not resuscitate patient, not for intubation patient. All right, we go up to 10, 12, 15 sometimes, but usually they are not doing well. The outcome is not great. So this is the golden figure for that. We won't go beyond the 10 centimeter water peak in CPAP cases. Any questions? OSA. But sometimes, exception. OSA is an exception. OSA, OHS. We go, some of them, one of the patients now in our ward is 18. But don't forget, they are not acute lung injury. Their lung is good. Okay? They are not acute lung injury. Their lung can tolerate higher setting. This is a different story. Okay? The CPAP don't go beyond 10 is for the acute lung injury. Pneumonia, ARDS, COVID, pulmonary edema. Alright. It doesn't apply for the OSA and OHS. OSA and OHS are good lung. I mean, not injured lung, not infected lung, not inflamed lung. Their problem is because of obstructed sleep apnea, why sleeping the tongue obstructed. And obesity, hypoventilation. Obesity is causing the respiratory muscle cannot work properly, and hypoventilation. So they need a higher pressure because their lung is big, their chest is big, tidal volume is big. So in OSA and OHS, they have their own setting, guided by the CPAP clinic. You can have a look at their record, what pressure they are using. If you don't know, yes, you can start with 10 or whatever. Okay? Any questions? You want a nap?
Yeah.
You want to go on breathing for a while? I think, should we open up the window a little bit to breathe the air? Otherwise, our brain is more drowsy. I'm afraid you might fall down, sleeping. So now we go to the biped. Oh, CPAP. CPAP also has inspiration, expiration. CPAP also blowing in and giving the pressure at the time of blowing out. It also has the pressure, but it's actually it is continuously blowing 8 centimeter water. Even at the time of breathing out, it's also delivering the same pressure to prevent the airway collapse. So actually, CPAP is not go like the inspiratory phase. This is not called the bi-level positive airway pressure. It's called the CPAP, continuous CPAP, positive airway pressure, because it's continuously blowing. At the time of patient breathing in, blowing. Breathing out, also blowing. That's why you cannot give too much pressure. Pipette. Pipette, blowing in, blowing out. You may see that two levels of pressure. So, pipette, pipette. Inspiratory positive airway pressure with the inspiration alongside. Inspiratory positive airway pressure. Actually, this is the same thing. Actually, the same thing like CPAP. At the time of expiration, it delivers a little pressure to prevent the airway to collapse. This idea is the same as a CPAP. A little less pressure at the time of expiration to prevent the total collapse of the airway. Alright. But giving a little more pressure at the time of inspiration because it's not suffocating alongside. That's why always IE ratio, IPAP to EPAP ratio is 2:1. Okay? If you use I5, E5, I10. If you use EPAP 6, 12, 8, 16, something like that. Inspiratory pressure, but as a rule of thumb, we never go beyond 8. Okay? 8. We never go beyond 8. But you can go up to 20, 22. but remain 8. Because as we say before, if you give the pressure at the time of expiration, they may feel suffocating. They can't breathe out. So never go EBET more than beyond 8. If someone need to go beyond 8, then need a specialist supervision. Respiratory team or intensivist team need to be get involved. They need to be consulted. But you can increase the respiratory IPET value. Okay? But sometimes in BDS guideline, British Thoracic Society guidelines, some may say you can go 3:1 in very obese or something. If the chest is very big, tidal volume very big. But roughly general setting, we won't use 3:1. We use 2:1 ratio. All right. Now I will go to how to adjust biped and what are the indications to start a biped. This is going to be a little important and busy slide, but I try to make it clear. Okay? So, first indication is actually CO2 above 6.5, right? But that must be pH need to drop less than 7.35. This is a must. Because sometimes CO2 might raise. Some of the patients raise 8, but their pH is still 7.4. Because they are trying to maintain it with the carbon dioxide or bicarbonate. Kidney is compensating. This situation we never use biped. Alright. So this pH is a absolute criteria. We start the biped. Alright. We won't start not only for the carbon dioxide raise. We need a both criteria. Carbon dioxide to be raised plus pH need to be dropped. 7.35. Alright. Okay? But this is a rough guide. Alright. This is not for the all case. Sometimes we may start without acidosis. For example, your patient coming with PO2 of 8. Alright. pH of 7.45. Okay? Bicarbonate of 35. Okay? This is called normal pH. Okay? Carbon dioxide raise, hypercapnic. Why hypercapnic? Compensated. So this is called a chronic type 2 respiratory failure. Why we call type 2 respiratory failure? Carbon dioxide raise. Chronic type 2 respiratory failure compensated by metabolic elements. Okay? Chronic compensated type 2 respiratory failure. This is a term. After 2 hours later, patient looks very more unwell, more tachypnic, and more drowsy. You repeat the ABG. And CO2 began 9. pH 7.40. Bicarbonate 40. Respiratory rate 35. GCS 11 and 15. Sometimes we may start NIV. That's fine. Even with the normal pH. Because your patient getting drowsy, respiratory more suffering. Bica is too much compensating. We know the kidney cannot compensate. Cannot withstand in another 1 to 2 hours. So if you didn't biped that patient in another 2 hours, what is going to happen is CO2 will become 12, pH will drop to 7.29, and Bica will happen at 44. So we sometimes we can't wait that this to happen. We may need to start biped in this setting with normal pH. This is a clinical judgment. We cannot make protocol. All right. So this protocol are just rough guide. All right. You can override at any time if you are confident enough to do so, and if you are trained to do so. All right. Guidelines are rough guides, and yes, sometimes we may need to break the rules. All right. So yes, usually we indication of biped carbon dioxide hypercapnia at the same time acidosis. But sometimes we may need to start. It depends on how the trend, severe trend. You know your patient well. All right. Don't even look at the single figure. How the trend is more important. Okay? Any question? Okay. So this page I'm going to talk about how to adjust iPad and ePad. Usually the decision comes from the medical doctors, but for the nursing staff, yes, also good to know, because we are colleagues. We discuss and we do our best for our patient, and mostly the nursing staff know the people better than the doctors because they spend more time with the patients. So if you have more knowledge, and your patient will get more benefit. All right. At the same time, we can discuss in friendly manner. All right. Sometimes nursing staff are more senior, knowing the patient and the machine. Some of the doctors just graduated; they might have the limited experience. We need to support each other as a team, not the rank or the role. All right. So it's good to know. So how to adjust iPad and ePad? So start talking about the ePad and positive airway pressure. So end positive airway pressure means it's delivering the pressure at the end of the expiration. All right. Alveolus is trying to collapse, but positive airway pressure prevents the collapse of the alveolus. So by giving the pressure, it makes the oxygen to stay in the alveolus a little more time. So it is called the alveolar oxygen capillary phase time. So the capillary, alveolar capillary and oxygen interface time increase by ePAP. If you increase the ePAP, you will make the oxygen to stay a little more in the alveolus. So ePAP will help to increase the oxygen. If you are struggle with the oxygen, you try to think about adjusting the ePAP. If your ePAP is 4, you may think to increase to ePAP 6. If your patient is not achieving the target SpO2. For example, your target SpO2 is above, 88 to 88, but you are not achieving, your patient is still hypoxia 85% with ePAP of 4, you may wish to increase to ePAP 6. So by increasing ePAP 4 to 6, oxygen will stay a little more, and you will see that your SpO2 will increase by increasing ePAP. All right. This is how we adjust this is the oxygen, and not only increasing the pressure. Actually, as I have said, regarding the oxygen, there are two: quality and volume. So the pressure is the volume. Actually, you are adjusting the volume. Always try to think of the quality first, because volume or the pressure can make the injury. Quality will not make the injury. So if your patient is only getting the 60% oxygen, you may wish to increase to 80% first before you consider increasing the ePAP. Or sometimes you may need to do both at the same time. Both increase the FiO2 from 60 to 80%. At the same time, a little bit increase the ePAP from 4 to 6. So how we adjust the oxygenation by playing with the FiO2 and the ePAP setting. Okay? So since ePAP is oxygen, no way iPad is for carbon dioxide. Alright, if you want to play with the carbon dioxide, you have to deal with iPad. So easier way for me to remember is carbon dioxide is a smoke. When the room is filled with smoke, yes. How to clear the smoke? We need to blow with something, fan or something, blowing in. So if you want to wash out the carbon dioxide, yes, you need to blow more. So I bet it's a blowing, like the hairdryer. All right, I bet it's just a blower. So if you have problem with carbon dioxide, blow more. For example, we start with 12.6, okay? I bet 12, E bet 6. All right. FiO2, 60%, for example. All right, this is the quality. All right. So after that, you start the carbon dioxide of 9. The patient has the carbon dioxide of 9. You start with this study. All right. 12.6, 60%. You start. After that, 1 hour later. So another one is after setting the pipette, you need to repeat the ABG 1 hour later, because we need to know whether our setting is right or wrong, or to know whether adjustment is required. 1 hour later, if your carbon dioxide is getting worse, 10. All right. Initial pH is 7.34. pH is 7.30. Okay? Your patient is getting worse after you start the pipette, right? Carbon dioxide getting higher. pH is further drop. Acidosis is getting worse. Okay? So in that case, what are we going to do? So, always think about the quality and pressure. Before you start the adjustment, check with the quality. Are we giving too much oxygen, causing the patient retaining carbon dioxide? Yes, of course, you are giving the FiO2 60%. It could be too much for your patient. All right. How can we know that? In the ABG PaO2 shows that 12. Of course, we don't need 12. We only want 8. You are giving too much oxygen, proved by the PaO2 12. So what to do? Reduce FiO2 to 40%. Okay? You still have time. 30 minutes later, you can repeat the ABG. And let's see. PaO2 drop to 9. Carbon dioxide drop back to 9. pH is a little getting better. Oh, okay. Oh, we are on right track. We don't need to adjust the pressure at that point. But sometimes you may wish to do at the same time if you can't wait. So you will give the order, reduce the FiO2 to 40% and increase the IPAC to 14.6. Oxygen is too much, so we don't need to touch the EPAC. Understand? You okay?
So I'm thinking like sometimes when you start like with patients on NID, like I think some say that it's normally wanted to you start the IPAC at a higher range, like maybe like the IPAC difference between IPAC and EPAC is like around 10 to make a difference. You think?
Well, yes, sometimes we can go up to, you are talking about the difference.
Yeah, the difference.
Yes, we will do so, 28 sometimes, different is 12. But as a rule, it's better to start low and go slow and adjust require. Because don't forget, pressure is always the injury. All right. So any question? It's a busy slide.
Yeah, ask my question, please.
You okay?
I'm fine now. Yeah.
You okay?
Yeah.
All right. Yeah. I'm asking questions to keep you awake. So we will do the some quiz, and after that, not quiz, problem, and after that we will finish. Okay, here's one. COPD patient, came in with pH 7.32, carbon dioxide of 9, bicarbonate of 38, alright, oxygen of 7. So hypoxia, hypercapnia, acidosis, this is respiratory acidosis compensated by metabolic component. So this is uncompensated type 2 respiratory failure because already acidosis. So we will start a biped. Okay? Agree? Indicator, right? One indication, two indication. Alright? We will start a biped. We better go slow. 12.6. Okay? Since we will go with FiO2, well, 35%. We are a little cautious here. So whenever, as a doctor, whenever you requested our nursing colleagues to start the biped, this is the typical figure you need to write. Could you please start the biped? IPAD 12, EPAD 6, FiO2 35%, repeat ABG 1 hour later by yourself. Or they will do if they have the outline. Alright. Okay. 1 hour later. Okay. Water plan is pH 7.30. Okay. CO2 11. Bicarb 42. Oxygen 13. Could you please tell me the setting of how I'm going to adjust?
Now increase the biped to like I think.
So what is the problem? What is the problem? Find out the problem.
Too much.
Oxygen.
Yes, too much oxygen. We don't need 13. We need only 8. So what are we going to do? We definitely need to reduce this. So FiO2 reduce to 28%. Agreed? We can go to 24. 24 to 40 is the range. Reduce FiO2 to 28%. Okay. So we deal with this one. So how to deal with this carbon dioxide raise? Increase the IPAD, right? IPAD increase to or 16 or whatever, 14, whatever. Plus 2 or plus 4 is fine. And what are we going to do? Do we need to touch with EPAD or not?
No.
No. Because EPAD is for oxygen. So keep the EPAD the same, 14.6. Okay?
Mm-hmm.
And don't forget to repeat ABG 1 hour later. Okay? I think we have finished. What else we can do? Right?
Yeah, because I think the other one is the helpful part for me is like the mask fitting, like because the mask fitting one is the
Mask.
so sometimes like I know that nursing staff they do try the mask fitting on the patient, but then like sometimes if the patients
But I don't know about the mask. I'm sorry. Okay. I think our nursing colleagues have more experience how to deal with the mask.
We don't.
Yeah, I only know that FFB doing mask.
I don't know. Well, how do you know tolerate it?
no, that's like I think some places like what I say is like the BiPAP mask and CPAP mask they are very tight fitting. So sometimes like in some certain cases like I think some scenarios it's like if the patient vomit into them, like what do we do to them, and if the patient's like cough into them, how do we put the patient on and how do we start? Like I think you're saying start at 12.6 and then for like CPAP, because you said maximum is 10, right? But
Yes.
for CPAP, so for patients who are like COVID patients, they're unwell, and you're going to put like a very tight fitting mask
Yes.
on them.
Mhm.
Like do we just start at around like 4, then go
Yeah,
up?
yeah. If you start lower, they will tolerate
and then just
more.
go 4, 6,
Yes,
8.
yes. But you need to aim the target situation, either SpO2 or ABG.
Okay.
If you are not achieving with the maximum setting or patient not tolerate, you need to consider alternative way. I mean, intubate or step down to HFNO, which is a little more comfortable,
True.
even though they're not the best. Now the RS recovery trial found that HFNO doesn't change outcome. HFNO is useless in COVID ARDS.
Oh.
Yes. So if you think the patient need the non-invasive ventilation, start the CPAP earlier.
Okay.
Yes. So that's why HFNO is only indicated in the weaning down when they recover. But they are in the accelerating phase of injury, not reaching the plateau, and they likely to deteriorate further in another hours or they are on the process of ongoing lung injury. CPAP is better. But you can use the HFNO when they're getting better, you weaning program, yes, as a step down. That's why I think since studying the mid of the last year, we prefer to use the CPAP earlier, straight, rather than wasting the time on HFNO. RS recovery trial released, I think, second third of the last year, 2021. Okay. Any questions?
No.
All right. Okay. Well, see you later. Have a nice day.
Thanks for filling.
Okay. Let's see.